Welcome to Health Reform 2.0, the only place on the internet for people with a curious mind and a desire for a better healthcare system. Here we take you on a journey of our current quagmire, tell you where it came from and why the government can't fix it. Along the way, we'll tell you some history, bust a few big myths, tell you a few stories, and give you an idea how we can work together and get the healthcare system we want. Let's get started.
Welcome back, ladies and gentlemen. In our last episode, we discussed how, as Maggie Myers put it, our current healthcare environment is nothing more than a purely predatory competition of all against all. We discussed how we got to this place, how it increases the cost for all of us, and it simply makes getting healthcare much more dangerous. This episode continues that discussion.
Let's talk a little bit about hospital versus hospital because actually, let's talk about doctor versus hospital and give your little thoughts on that because this is, again, another thing that I don't think folks understand the predatory nature of what a doctor has to deal with when dealing with a hospital system.
Well, it's getting exacerbated because more and more, there was a period of time when doctors had control over much of healthcare through the power of the AMA and the power of the physician and the ability of the physician. Hospitals really didn't provide that complete healthcare service. They just provided a location for certain specialties to do the things they needed to do. It's one of the reasons that in the 1940s, there wasn't a very good network of rural hospitals because they couldn't afford X-ray machines in those days. They couldn't afford to have psychologists. They couldn't afford to have psychiatry. They couldn't afford to have a number of other specialties, including surgeries, because they couldn't have 4 or 5 surgeons in a small town because there wasn't enough surgeries for the doctor. The doctor couldn't make any money. So they had aggregated all the physicians together in these major educational institutional hospitals in big cities, and rural communities didn't have that. So we passed a law called the Hill-Burton Act in the 40s that stimulated the growth of rural hospitals and gave subsidies to those hospitals so they could afford to pay regular wages to subspecialists and specialists in care, which gave rise to the growth of specialists because, frankly, in the 60s, you didn't have all the specialists out there that you have today. Most of the people getting out of medical school are not general practice medicine doctors. They have moved into some specialty because being a GP doesn't pay all that much. So doctors don't really have much control over hospitals today. Most hospitals are controlled by the doctors, and they can determine if you're a surgeon when you get OR time.
Oh, yeah, it happens all the time, especially if you're a high production surgeon.
Exactly.
And believe me, orthopedics is the number one driver of revenue in any of these hospitals.
Exactly. So sometimes you have to wait to get an OR, not because your case isn't critical. It's just another doctor that has a better track record at bringing revenue is getting the time in the ORs. Yeah. Now, that's not in all hospitals, but it's clearly in some.
It's in a lot.
Yeah.
So doctor versus doctor, you probably don't really feel this, but it exists. An old Swahili proverb, when elephants fight, the grass suffers. Well, we're the grass, guys. So at the end of the day, there's an example that I use all the time, and that is the example of a tumor board. A tumor board is a group that gets together, usually a nutritionist, a radiologist, he never comes, by the way, a radiation oncologist, and a standard medical oncologist. And they discuss the cases and they compare them to other types of tumors they've treated. And supposedly they come up with a course of action. And that course of action is then carried out on the patient. And hopefully chose the right one. What happens in the tumor boards? It's doctor versus doctor. The surgeon wants to cut it out. The radiation oncologist wants to zap it, right? The interventional radiologist wants to ablate it. And it turns into this frenzy of really negotiating. And I believe there is some medical science associated with it, but When you go in there and view that, everyone's operating in their own best interest because they want the revenue for the procedure that they perform.
If the whole world, if the only tool you have is a hammer, the entire world is a nail.
Exactly.
When I was going through my process, you may remember one of the things I had to do was have gastric surgery to identify the source of a bleed I was having that was causing me a blood chemistry problem. And I went and the radiologist did their x-rays and the sonographer did their ultrasounds. And then it came time for my gastroenterologist to come in and repair the surgery. And a couple of days before the surgery, I got a call, said, by the way, he's not doing your surgery. The interventional radiologist.
Right. So perfect segue. Yeah.
So I had a radiologist actually doing the procedure in my stomach that normally a gastric surgeon.
Well, you were probably better off. This brings me to a good example, perfect example, good segue. Patient comes into the ED, with cramping in the leg due to lack of blood flow. In the past, the vascular surgeon would call an interventional radiologist, we call him an IR guy, or girl, there are very few females in that area, by the way, in to consult, decide which procedure was the most appropriate for this case. Today, he probably won't even mention to the patient that such a thing as an interventional radiologist exists. That's my experience anyway.
Yeah, and I think it's true. And if you look at what's happening in radiology about doctor versus doctor, you can get down to specialty of the doctor versus other doctors. You have radiologists that want to control the diagnosis of breast cancer,
right.
And you have ultrasound people that can do the same thing and in many cases do it better. But ultrasound as a solution for breast cancer, particularly in dense-breasted women, is not getting a foothold.
No, it won't either.
And it won't because the radiologists are much larger, have more money, and are controlling that part of the medical system. So that's another example of competition between doctor and specialty and other specialties.
Right. And by and large, except for IR people, IR docs, most radiologists are lazy.
Yeah.
Back to the hospital versus hospital. And again, bring it to life. Watch TV. Just watch TV, at least here in the West Coast. Look at the ads that show up every night. Dignity Health. Kaiser, which has a tremendous marketing program. You're going to see Banner in some cases. You're going to in other markets. They're all competing against each other. You go to Pac Bell Park, which just changed to, what did it change to? I can't remember. You got to tell me that behind home plate, there's a signage. And that signage is for Dignity Health. Do you know how much that costs for that signage behind home plate at Pac Bell Park?
Hundreds of thousands of dollars.
Oh my gosh. It's more than, I've seen it where the UC system advertises there as well. If you go to a Padres game, right up there on the scoreboard, to the right, UCSD Medical. That's our taxpayer money paying for that sign.
Exactly.
It's highly competitive, ladies and gentlemen.
And we talk about, there's not enough doctors, there's not enough room for patients, but that's just not tacitly true. And even if it was the case, going back to the concept of these what are called disproportionate share hospitals, we call them DISH hospitals, that treat the underserved predominantly, the indigent, the homeless, the people that are, I often call the most fragile among us. Those hospitals can't keep their doors open anymore, because the way they're getting reimbursed is based on keeping a better outcome and, frankly, not having the patient readmit again. Mm. And when you got a population you can't manage, they get readmitted because they're just not doing even close to what they're supposed to do. The average person, Tim, goes out from a hospital and gets medication from a physician. Do you know what the average adherence rate is for people actually taking the medication that they're supposed to take?
Probably less than 40%.
Well, it's a little more than that, 68%.
Oh, that's better than I thought.
But it costs a hell of a lot of money for the readmits going in. And you look across this whole thing. Now the competition is to get patients that are coming in the door with good reimbursement rates. So it's no longer the game of just advertising the hospital. It's advertising the hospital in a very specific niche where they actually have a foothold that they can use. So now they're actually advertising to change their patient mix.
And that's exactly what Kaiser's been a master at.
Oh, yeah.
They're into the population health, wellness. They want that segment of the population in that sweet spot.
Mm-hmm.
And they also want the Medicare patients because they can bill that all day long.
Exactly.
The other thing I'll talk about, and let Tom talk about that too in a minute, is drug maker versus drug maker. So now, if you still don't believe it's predatory, turn on your TV tonight and watch how many commercials come on there for a specific type of drug.
On any channel.
Any channel.
And listen closely to what that drug can do for you that is negative versus the positive. The positive will, and I'm making this up, the positive is we're going to eliminate acne. The downside is we can cause acne, we can cause a heart attack, we can cause your lungs to bleed, we can cause you to have rectal bleeding, we can put you in the hospital, you'll feel depressed, you'll want to commit suicide. And while those all putting them together sounds like a joke, if you look across these ads, I guarantee you, you will see every single one of those side effects for these new quote unquote wonder drugs. Many of them, by the way, are biologics, which is not attacking biologics, but there's lots and lots and lots of side effects today in the medications. And drug companies are now desperately competing for your dollar for their biologic that they just put in the marketplace. You've got 3 or 4 drugs out there for psoriasis that all end in MUMAB, M-U-M-A-B, or M-U-L-I-B, or a number of other things. But when you see those strange endings that are the same, that's because they're a biologic, and those endings actually mean something, whether it was produced in mouse or it was produced in humans or produced in cows or bacteria. All those little endings mean something. But and it is horrible. It's just horrible amount of competition for drugs that are marginally effective and come along with massive amount of side effects.
And we'll talk more about the drugs and the rebates and things that are not being brought forth publicly. But it's interesting, in 1997, the FDA gave the pharmacy industry, surprise, surprise, its blessing for direct consumer advertising. I wonder how much lobby effort that took. By 2005, and I don't know what it is today, I don't have a benchmark, the pharmacy industry's budget for direct consumer advertising is $4.1 billion. It's got to be close to double that today. The latest estimates, the drug companies spend more than twice as much on ads, marketing, and administration as they do in the lab. Mm-hmm. So just watch it on TV, ladies and gentlemen. You'll see what we're talking about there.
But a word of caution, if you think this means that these drug companies are somehow making hundreds and hundreds of billions of dollars because they're preying on you, the patient, because the cost of their drugs that you see all over the place are so high, that's not correct. Yeah, drug companies can make a lot of money, but they spend a lot of money to get there. And you can't look at what they pay for a drug in the U.S. and compare it to what they're paying for a drug in France, because there's a very fundamental different cost structure. In the United States, when a drug company sells a drug through any federal state program, they have to pay a mandatory rebate back to the federal government or the state, and in some cases to both. And those rebates range from 17.5% up to over 50%. So when you think a drug company sold a drug for $100, on average, they probably sold the drug for $30.
So, Tom, is that rebate applied just to the medications going into the CMS reimbursed population? I'm sure it doesn't apply to the private sector, right?
Many large purchasers of drugs negotiate rebates as well, as do distributors. Right. So, but in other countries, that's the case. The thing that's different in the U.S. is there's a mandatory federal rebate that flows through anything in a federal program. Federal programs spill over. Federal programs include Medicare, Medicaid, any federal program like the Ryan White CARE Act, S-CHIP, federal programs that support states in Medicaid or in Medi-Cal in California, TRICARE, which is military, and VA, and a number of other things. A large segment of the buying of medications in the United States is through the government in one form or another. So it is a big piece of the pie, and it is a large cost to the drug company. So when you see that I can buy this drug in Canada for $29.95 and it's $35 here in the United States, don't blame the drug company. Blame the U.S. government. Blame the damn system.
Which brings me to a point, and correct me if I'm wrong, I may have my facts a little bit out of order, but when President George W. Bush negotiated and introduced Medicare D, I believe that's
Part D.
Part D. Mm-hmm. In that negotiation or that deal, the stipulation is that the United States government would pay list price. They could not negotiate down the drug prices. Surprise, surprise. I wonder why that is.
Because they get a bigger rebate.
They get a bigger rebate.
They didn't negotiate the price down. They just took part of it under the rebate.
And this is not being brought up on any of the media. I haven't heard it at all. Just a little soundbite here and there. It's a huge factor. So when you hear about the big ugly drug companies and how we're going after them and all this kind of stuff, the U.S. government's created this problem.
Exactly. And you don't hear much about it because it's a good way for governments, state and federal. That money flows back to them in their general budget. An example is HIV and AIDS. With HIV and AIDS, money that is spent under that program is supposed to go back into a state program in the rebate. The rebate's supposed to flow directly into buying drugs in those state programs. But many states don't do that. They flow it into the state general fund. A little bit of it may flow back into HIV and AIDS, but they're taking what in California might be a $500 million claim spend for drugs, and it's really about $243 million that California is spending. The rest of it's coming back to California in the form of rebates. Now, California does put it back in their HIV and AIDS program. They do put it back in the AIDS Drug Assistance Program in California. But like I said before, not all states do that. And the federal government takes it back in their general fund, and they can redistribute it to just about any place they want it to go.
Exactly. So one more segment on this predatory environment, then we'll get on and close out this segment. Briefly, insurer versus insurer. Talk a little bit about the medical loss ratio.
Well, there's some interesting things because in one of the articles we're going to be talking about over the next few weeks, they start talking about how they're aggregating these things together from insurance companies, from hospitals, and they're delivering back, 23 or 24 more cents back to the public as a benefit. Well, in some cases, they're delivering back part of that money because they're in this thing called a medical loss ratio. It's also called a risk corridor. And the way it works is insurers are now statutorily mandated that they can't make more than 15% on the difference between the premium and what their costs are. If their margin goes over 15%, and by the way, that isn't just the money that goes in their pocket. There's a series of expenses that they can use, and then others which doesn't cover the whole cost of running that company. Right. But they were mandated they couldn't make more than 15%, and if they did, they have to give a rebate back to the insurance company or the patient that they're covering. Now, part of that got suspended because the federal government, Supreme Court came back and recently said, I think last year, that, oh, by the way, it's against the Constitution for the federal government to provide money back to the state to pay for insurance companies. They can do it to give it to the patient, but they can't do it to the insurance company. So if you noticed in 2017, you started to hear the talk about prices going up.
Right.
Prices are going up because the risk corridor, it basically got ripped apart in terms of the ability to pay rebates back to these. And up until last year, Trump was withholding about, I think it was $30 billion.
Yeah, I don't think they'll ever get it.
Yeah, I don't think so either, because I think at this point they're not eligible for it. But that money was going there so that the Affordable Care Act programs could be subsidized by the risk corridor to lower the price that they were released at. So when you saw those very low prices in 2013, they were low because everybody was having any losses they made up by the government. But today they don't get any losses made up. So now you're getting back to the real pricing. And guess what? The real pricing of those programs is a hell of a lot more than it would have been if we'd stayed on the old system.
Very true. So what does this mean? I hope you're able to take away a little bit about just exactly what goes on in this environment. And it's highly competitive, much more than I think most people understand, unless you've been on that side of the equation. So what's the real outcome of this? Well, caught in the crossfire. Patients, us, whistleblowers who tried to change things. Again, took a little information from Maggie Marr's book, Money-Driven Medicine, kind of paraphrase. Providers views patients as fair prey, chattel, I think you mentioned. Mm-hmm. The root problem, they say, is the peer review process designed to monitor the quality of care and physician competence. I'd probably have to agree with that to some extent. Healthcare organizations are controlled by powerful, producer-led interests. The dominant position of healthcare corporations and professionals give them a political and economic clout to block changes that would reduce the power and make them more accountable, even in the face of pressures from government, patients, and the media. They would never let Microsoft have this kind of power, but it must be okay in the medical industry. Tom, how does our solution solve for this problem?
Well, our solution changes the entire structure of how healthcare is managed and operated. It doesn't change the way doctors deal with patients. It doesn't change practice models. It doesn't eliminate the need for an insurance company. It doesn't eliminate a drug company. But what it does do is it sets up a series of methods for us to prosecute what we want in a healthcare system that has checks and balances across each and everything that we need to do. And it sets up a structure so that these games stop. It demands the elimination of all rebates in the delivery of healthcare, federal and otherwise. It demands that pricing be set at what is fair market value, or as they say, usual and customary repayment price, so that people really get a good handle on what things are supposed to be paid. Not what they cost, but what people expect to be paid. It changes the relationship with doctors and hospitals. Doctors go back to being truly independent practitioners. Hospitals become places that provide services for the aggregation of care. So physicians and specialists still go there, and hospitals can still employ them. But their compensation system becomes uniform across all physicians, across all providers. And the method of managing it becomes integrated around patients in the center, but not institutionally centered patients, but all patients as individuals. It is a truly patient-centered system. So it doesn't make a difference when I go to see Dr. Y and I see Dr. X today, whether they're in the same network or not, because there won't be any networks. In effect, there will be one network, the network of authorized physicians. There will be one group of people that were willing to pay part or all of a bill, and then there'll be a series of providers that provide the services for that, and everybody now is connected to everybody, and payments and things can process that way, and it puts the patient in control. But we need one thing that is clear to anyone. We need to get somebody in the loop. We call it a facilitator, an advocate, that is going to help the patient when necessary, make all the little things that have to happen across all the various players come together, and they will have a great tool in the system that we've talked about putting together. At the beginning of the show, I told you that my healthcare cost $1.2 million, and I didn't care. And I don't care. I don't care that it cost $1.2 million, because it didn't. It didn't cost $1.2 million. It cost $720,000. Did it need to cost $720,000? No. It probably could have cost 20 to 30% less if we used the system we're talking about, because the pads that are built into the system, in order to get the money in the system to actually pay the cost, which is confusing to everybody, they go away. That's number one. But number two is, why is it I don't care? Because all of us, doctors, drug companies, insurance companies, providers, and us, American people, we allowed this to happen. We demanded, frankly, that this happen. We've been demanding that they give health care to us, in effect, for free for years, and they couldn't do it. We've been demanding that they have cures for everything, and when they don't have cures, we want to sue, but they don't have cures for anything. So we've built an environment where doctors basically don't tell the truth sometimes, where people that can do jobs in healthcare aren't allowed to do them because the doctors need to get that income in order to cover their costs, where hospitals have to try and negotiate doctors in a corner and negotiate insurance companies in a corner, and insurance companies try to do all this. And we build a false economic system that hides everything from us. You want to blame somebody for my $1.2 million? Blame your goddamn self, because I'm blaming myself. If we want to stop this stuff, we need to do it. And the whole point of these shows are to get to the point where we can start to do it.
Good point. So one more thought for me, and then we'll wrap it up. Lots going to happen between now and this next election cycle. We saw it with the midterms. We've already seen a number of things. We're going to have a segment coming up on the terminology. Now, some of you on Facebook, and by the way, I will never participate in Facebook, so if you think I'm reading it, I'm not.
I read it. I'm designated as the guy that has to read it.
I absolutely boycott Facebook. But some of you accuses us of being partisan. We're not. You've been on Capitol Hill a lot. I've been on Capitol Hill some. I don't like any of them. Not one of them. And I personally think that we're doing ourselves a disservice by continuing to reelect these people time and time again. Now, you can argue about Medicare for all. You can argue about single payer, which is the most ridiculous used system or terminology I've ever heard. And we're going to talk about that in the upcoming segment. What we're talking about is health care that we can provide to our population, the American people. And we can do it across the entire system, if you want to call it that, because that's what we're advocating for. The difference is we can provide that for people and we can give them life care solutions. The difference in ours is what you need and what you want. Two separate discussions. It's not a partisan issue. We can cover the people in the United States. And when we get into the segment of waste, fraud, and abuse, if we just solve for a fraction of that, we would be in a much better spot financially. Because pretty soon we're going to hit 25 to 26% of GDP, and we're going to be a real problem.
And we're inflating GDP every year because we're printing more money to put in the economy so that we can afford to pay for these things. So in effect, we're using dilution of our own value of the dollar in order to build a myth that somehow or another we're actually making more value in the process, and we're not. We're diluting the value, providing more and more services, and then putting that on the back of the middle class who don't have the ability to leverage the growth in the market or access to the funds of subsidies that the poorer people need to survive. So it's a horrible quagmire. It covers the economy and healthcare, and it can be rectified, it can be fixed, but we, the people, have to do this.
Exactly. So we'll sign off on that. But just beware, folks. It's getting real. We're going to be bringing up some very, very probably controversial points. We'll use data to drive those points. We'll try to be objective as we can. We went through the history, which was very encouraging to understand and read and understand how that worked, why we got here. I think it's important. But now we're in real time. And this podcast is going to get a little bit more, shall we say, controversial.
Hey, you know what? We didn't drop one F-bomb during this show.
No,
and
we
that's
haven't.
one of the things that one of our viewers said, you guys need to get more emotional. Use the F-bomb now and then. So stay tuned.
But then iTunes would put us on a bad list.
Yeah, maybe we will.
Yeah. Thanks, everyone.
Bye, guys. You've been listening to Health Reform 2.0 with your hosts, Tom Locher and Tim Henning. We hope you found the topics interesting, that we answered a few questions, that you laughed a bit, and were entertained. Please feel free to invite your friends to join the discussion, and remember, hit that like button and don't forget to subscribe. Send us your questions to info@hr-20.com. We hope to see you again next time.